Okay, sorry about that, guys. We're going to try to find a mic so we can walk around and talk to you guys. I would hate to stand at the podium all day long, so we'll try to figure that part out. But these are the disclosures. There's just one disclosure by Dr. DeVos, and it's important for us to make sure that we show you guys this disclosure statement, and note that the opinions expressed during the live activity are those of the faculty and do not necessarily represent the views of the University of Cincinnati. The information is presented for the purpose of advancing the attendee's professional development. And in order to get your CME, you can log into the app or the website, locate the Claim CME button, select certificate type, click complete the survey, and there's really 4 short questions. Then you can download the certificate and save it. So definitely get your CME. I think it's going to be worth it. So again, welcome to the WHO ICRC Basic Emergency Care course. The first presenter today is Dr. Patel, and Shama Patel, but we can be formal. Dr. Patel. She's an integral part, you can use this, of this course, helped establish it, helped create it, is regulating it. So we're really happy to have you here. Shama, thank you so much for joining.
So this doesn't work, right? This thing?
Yeah, that works.
Oh, okay, that works. They want us to talk in the mic?
They do for now, and then he's going to bring the mic up and we'll switch out.
So, yeah, just a background. I've been doing BEC since 2018. We've run about 40 in Ethiopia, and I've run them across the country, or the world, I should say. And now, if you do want to certify a course through IFEM, I'm your point of contact, so you guys can get my email. It's super fun. I'm a certificate factory, basically. I just approve courses. And then we'll talk about it later, how to get a course approved by IFEM. There's a process to it. So just background. So this is a pilot of these slide set. So basically what happened was, before you had to do a TOT, sit for a BEC, and then you become a provisional trainer. The problem is there's a lot of EM specialists out there that don't need to sit for a BEC because it's basic emergency care. You guys, we all know it. So this has been created by the WHO to fast track providers that already are EM specialists. So in countries, and so you don't have to sit for a BE, like a full BEC 5-day course anymore. This will count towards you becoming a provisional trainer. This is pilot, right? This is on a pilot basis right now, so we can't share it yet, but it should go through the process of WHO. So this is just something to know. It's important when you're advocating like globally for global emergency care. If you look, the cost per year life gained for emergency care, so for a staffed community ambulance in the rural area, it's $284. Staffed community ambulance in the urban area, $94, and trained first responders, which is the lowest hanging fruit in a lot of ways, is $7, and then antiviral therapy is $922. So when you're advocating in countries for emergency care and emergency care systems, this is a great slide to show and be like, listen, this is how cheap it is to save one life compared to antivirals are also important. Like I did HIV before, that's great, but emergency care it's systems based. So priorities in global health. So we've been siloed for so long, right? The PEPFAR, for those of you who know it, the Global AIDS Program, HIV, malaria, TB, it's always been about the disease process. It's never been about cross-cutting. So you guys have heard about One Health and all the new initiatives of planetary health. All that stuff is to look at more horizontal programming versus vertical programming. So not looking at diseases, but looking at the systems that create those diseases and creating an environment in which we can address multiple ailments and diseases at once. So primary health care, emergency, obstetric care, global surgery, and emergency care. Obviously that's the most important, right? But no, global surgery does a great job. Primary care is getting more involved. But really you want to look at we're a horizontal program, and we cross-cut all of these disease processes and more. And so the emergency care toolkit, so we'll talk about all the tools that the WHO has. It's a long time in the making, and a lot of people have worked on it. But when we say the BEC Toolkit, it's these 5 things. So it's the Basic Emergency Care course, which is a 5-day course. It's standardized trauma and medical checklist and standardized charting, as well as a resuscitation area and triage. And the triage is based on the ICRC MSF and WHO triage system of green, yellow, orange, and so introduction, just background. So what is a BEC? It's Basic Emergency Care course. It is for providers it's open access, but it's for frontline providers, so like health officers, general practitioners, equivalents of PAs that do not have emergency care training. So it's not for emergency specialists. The emergency specialists are the ones that give the lectures. So it's just that, and it's the basic approach for the acutely ill and injured. And so when we go through the components of the course, you'll ask yourself, and everybody always does, why is this not included? Why is this not included? It was a huge consensus over multiple countries, over multiple people that decided these were the most important things to continue, which it included. Developed 40 countries, 4 years in the making, co-developed by the World Health Organization and International Committee for the Red Cross, and endorsed by IFEM, and piloted. So this is a little bit old. It was piloted initially in 3 countries. I think now it's been over. Last I checked, 22 countries have now done it throughout that have been at least from IFEM. Like I think it's open access, so people can do it outside of IFEM, but we're just trying to streamline the process so that we know the quality is being ensured. So a few thousand people is probably tens of thousands of people have probably been trained, a few thousand in Ethiopia alone, I know, and then in other countries. So it's the ABCD approach that we use in emergency care, airway, breathing, circulation, disability, and etc. And it's able to identify and provide interventions for life-threatening conditions. So the whole point of this is not for them to become, what we do, think about the differentials of what's going to, kill you, but it's what can be done quickly in the field that you can do the action, stabilize the patient, and transfer the patient to definitive care. Because really who we're treating are the people in more rural areas, not the ones, because in most countries, the EM specialists are in the urban settings. And you want to, this is a big point, and it's a point in the BEC that understand when you get there and ask for help, that it's not your job to, sure, yes. Now I feel like a singer. Does this work? Teaching strategy, it follows a student-centered philosophy. There's different approaches. So there's small groups, there's interactive skill stations, there's how to give a lecture, there's all these different components to it to engage the learner. And it's based on teaching theory and learning theory, so hopefully it does work. And you want the ratio to be 1 to 5, so 1 instructor for every 5 participants. It can be stretched to 6, but really after that we get really a little bit wary that people aren't getting the care, like the one-on-one care that we want them to get. And you want to make it as interactive as possible. We'll go through the schedule. I'll go through the schedule later. And you want to kind of do lectures and skills and have them as interactive as possible. Because what happens invariably is that the skill sections and all the interactive sections take more time because people have more questions during that time than the lectures. And you'll note that the lectures, and even these TOC slides these are the ones that you give, are very wordy, but that's because a lot of our learners aren't native English speakers, so this is to help them, because of their visuals, what's not included. So, obstructive delivery and unit resuscitation, because there's the EMOC, there's a whole series of courses that WHO has on that. CPR, because CPR is very controversial in many countries, even in this country, about what is effective CPR, isn't effective, what drugs to use. So CPR is not included. And you'll get a question during it, like during BEC a lot of times, what about CPR? And a lot of times I just say refer to your local protocol because they have their own protocol for CPR depending on what resources are available. Advanced airway management, this is really important because people that are in kind of suburban areas might feel like they can intubate or they can have some sort of adjunct airway. We're not teaching that. If you want to teach it, you can add it on, but it's not like considered part of the course. And then advanced trauma skills, so just and things like that. And needle throat anatomy is so it's the immediate action that's taught, not the definitive. Right. And then Miles is going to talk about who are we teaching. Any questions on that, guys? So yeah, and I'll talk about the whole how they certify a course and all that.
Yeah, that's so important because the certification process, thank you so much, has really changed. This fast track is such a great option. So before we had to sit for the TOT, and then we had to go through an entire BEC, which was at the start of it was very difficult to find. And then you can become a professional trainer, and then to become a master, you have to go through another 2 BECs, and it was quite the process. So this fast track process is really great for you guys. This is just really recent, happened, I don't know, the last week or so, I feel like. So congratulations, because that's a really, really big deal for you guys. So who are we teaching? We are teaching basically the entire emergency team in a specific location, usually a low and middle income country, where there is no lack of resources, and where there is not formal emergency medicine training. So you have to think about the context and the participants' level of emergency care literacy. I highly recommend that hopefully you have an opportunity to go into a country and maybe do a needs assessment and really figure out what is it that they need, what topic, for example, do they really want to learn. In the needs assessment I did in Rwanda, I have to say the biggest module that they really wanted to learn about was surprisingly shock. And usually I would say the topics that they would want is obstetrics care and delivery, or pediatric care. I think those are the 2 big topics, and unfortunately the BC doesn't include those 2 big topics, but it did include shock, which was fantastic because that's what they wanted and needed. So what is the setting in which they work? That is what you also want to consider, because you need to know what medications they have available. So it's really a great idea. I know most of you guys know the countries, know the people of the country you guys are in, or working in globally, so you'll probably have all that information. So that's where it will occur. And like I said, the whole emergency care provider team is the way to go. So I would say if you can have in one BEC session, if you can have nurses, paramedics, and paramedics, for example, in Rwanda are nurse anesthetists and nurses. So whatever it is in your respective countries, nurses, paramedics, clinical officers, doctors such as general practitioners who don't have formal emergency care training. But if you can have all of them in one group, I think it works out so well. Because the doctors tend to really help answer questions. They try to actually answer questions in a way that's appropriate for that local context. So they'll give examples and they'll give medication examples, and it's really important to have that sort of interdisciplinary team. So I think that works out really well. Everybody tends to help one another. And it's important that the team all understand the same basic emergency care concepts, and the same information is relayed to the same team. The course structure and content, we talk about life-threatening ABCD conditions. We talk about altered mental status, shock, and difficulty in breathing. Those are the main, and it's of course trauma, can't forget that. Those are the main core modules of the BEC. And you'll see the book, if you guys have the book already, or do you know that it's online? Okay, so the BEC book is online on the WHO BEC website. And you'll see that the book is broken up into those categories. It's really important to kind of run through that entire book actually before you teach the course. Because to be honest, it can be a little bit confusing if you've never actually sat in a BEC before. So we're going to try today to kind of show you, not the book itself, but the case scenarios that are involved in the book, the simulations that are involved in the book. But take some time before you do the BEC to read through some of the content, because you'll see, for example, that there are a list of vocabulary words that the participants have to fill out. And so you'll see some of the items that the participants actually have to do in the book. One of them is filling out the vocabulary, the other one is writing in case scenario information. I'm going to run through some of that today. Pediatric and pregnant considerations are integrated throughout all modules. It's just not obstetric delivery itself. And in addition to the BC course structure, you have lectures that are interactive and participatory. We have case scenarios within small groups that are interactive, and we'll show you that today. Skill stations that provides hands-on practice, interactive large group discussions about medications and handover and transfer. And I would say it's great. I think the best way to structure it when you do the BEC locally is to have a few lectures and then try to break up into a case scenario and have another few lectures. You know, kind of sprinkle in skill stations. That tends to work really well because people aren't just sitting and listening to a lecture, right? So the more interactive, the more people can get up, the better it will be. We also have medication jeopardy, which is so much fun. I mean, when we did it in Rwanda, right, Travis was like nodding yes. They were so quiet the entire day, and eventually we did the medication jeopardy, and it got very tense and competitive. Shouting at one another. But it worked out really well. It was probably the best part. What did you say, Travis?
In a good way, though.
In a really good way. It was fun. People were laughing. We were enjoying ourselves. So medication jeopardy is so much fun. And then the handover lecture, I think, is fantastic because that is the crucial part about the BEC is that you're in an area that doesn't have the resources, and that provider needs to know how to transfer a patient to a higher level of care. So also a reminder that content can be added to the BEC but not removed. That's super huge. Really good point. So it's important that if you are, for example, in Rwanda, that you add context related to, the local context, right? So there are a lot of, for example, pothole injuries. You just, are walking down the street and there's like a hole people fall into. That happens a lot. And so a lot of the examples of trauma came from that, where, people to understand that better. Or animals, when we talk about fights or animal bites, using the animals of that country, using like their flag. I mean, just there's so much you can do. Also, what we've learned is that having the course taught in that country's primary language is very important. I have to tell you guys that I asked ahead of time, did a needs assessment, asked what is the language that you prefer, and they had said English, but this was the test of those people who were going to participate. So they had said English, but when we got there, I would say approximately 6 people only spoke French. And so we were really thankful that a lot of our facilitators were BEC trained back in Ethiopia, and they were able to do the lectures in French. So that was super helpful. So some of the things to consider globally, which I'm sure you guys will as you work in your global context. So this is an example of how the course can run in terms of days and time. So the BEC you see is in this kind of like salmon color, and it's day 1, 2, 3, 4, 5. So usually 5-day course, and can run from like 8:30 to about 5:30 p.m. And the TOT is usually 2 days. I have seen the BEC, the TOT be shortened to 1 day, but I highly recommend not trying to change the schedule, to be honest, because doing the BEC in less than 5 days is extremely difficult. To try to, basically, you would have to do that, you have to be there until like 8 p.m. It's a very intense course. We know the emergency care content, but remember, we're teaching people who do not know emergency medicine. This is information that is all new to them, and it takes time for them to digest and learn. So you really do need all of that time. The case scenarios take actually the longest amount of time because people are, actively learning, sitting in groups and trying to understand the material. We even had, I think in Ethiopia, I don't know if you remember this, at the hotel, the nurses were gathering in the restaurants and they were teaching themselves the material even after the course had ended each day. So we ended the course at like 6 p.m. each day and they were just studying until 8, 9, 10. So it's a lot of information for them. So I don't recommend shortening the days. We did have to do that in Rwanda because we just didn't have enough staff to keep working clinically, so we had to do what we had to do, and it worked out well still. Any questions about the schedule? And in order to complete the course, the participants have to complete a pre-test, just like you guys are doing for the TOT. So they have to receive the participant manual, try to pass those out to them 1 week in advance. They have to attend all sessions. You use a sign-in sheet for both morning and afternoon sessions every single day. I have to tell you, we did have a few people that kind of missed the afternoon sessions, and I let them miss one, but they were notified and they didn't have to attend the rest, otherwise they would not receive their certificates. We have to be very strict about that because there's so much material. And if you miss an afternoon session, that's a lot of stuff missing. Complete all workbook sections. If you take a look at the BEC manual online, you'll see that they have workbook sessions that they have to fill out, like the vocabulary I was mentioning. Complete all skills tests, meaning simulation skills tests. And by that I also mean that when you do a skills station, there's supposed to be a document that assesses their skills. So successfully manage one case scenario, we'll practice that today, and then pass the final written exam with a score of 75% or greater. And I think that was one of your pre-test questions, so 75% or greater. All right, so the BEC TOT Fast Track for experienced providers and educators. Shana, you talked about this, right? Okay, so this is a specialized fast track course offered to a select few. This course presupposes that you have read the manual and understand the content. The usual pathway to facilitator progression is much more time consuming. It's a 5-day BEC provider course plus a 2-day TOT course. But at the end of this 1-day course, if successful, meaning you pass the test, you will become a provisional facilitator and you'll still need to teach a course under the supervision of a master trainer before you can teach BECs independently. Because I get a lot of questions about this, so this is a really important slide. Take a picture if you want. Just remember, this is, okay, take an actual picture. It's important. All right, good. So this was the original certification process, where you take the BEC course for 5 days. Once you take the BEC course only, you're a BEC trained provider. And this is information for, the participants that you're going to give to them. So this is still the case. BEC 4 or 5-day course they have to complete. They're then a BEC trained provider. Then you can select a few people that you think were fantastic in the group sessions. They were explaining things to the rest of the group. They were actively participating and engaged. So it's your job during the BEC and the local providers and local trainers to choose who will be the future trainers. So you kind of have to pay attention during the BEC. And so that you're going to choose those people, and they're going to continue on with the last 2 days of the TOT session. Then that means that once you've completed BEC and the TOT, your provisional facilitator. Then they have to teach a BEC course with a master trainer supervision. And once they do that, they may teach BEC courses independently. Then when you teach 2 BEC courses, you're a master facilitator. Okay, so this is also a very important slide, good for the participants on the ground to know. Any questions? All right, certified as versus certified to. So to make this simpler, I'm just going to tell you this is basically the same slide as before. Again, if you're a BEC provider and you did the BEC provider course, you're a BEC, sorry, if you did the BEC course, you're a BEC provider. If you did BEC and TOT, you're a provisional facilitator, and so on. So it's the same exact slide, just laid out differently. Any questions about that? That's a great excellent question. Yeah, excellent question. So we recommend that when you are doing a course globally, you have the sponsorship of a global emergency care group. So for Rwanda, that was the Rwanda Emergency Care Association, also known as RECA. Kenya has its own emergency medicine foundation. And so you want to find that sort of organization. You also want to involve the Ministry of Health if possible, and make sure that the course is approved by them, because one, you want to have their buy-in to promote this sort of course in the future. And eventually we'll be able to hopefully fund it in the future. RECA for the BC Rwanda was able to supply a bit of funding. The rest of it was actually a GoFundMe page that was created by that group and worked out really well. We got approximately $7,000. And to be very frank, most of the money actually goes to catering. Putting together books costs approximately $500. And catering is really important there because they anticipate, right, having tea, have tea time. We have like our coffee, we like the tea. So morning chai, afternoon chai, all very important. And usually like a buffet type of lunch. And that costs approximately $1 million Rwandan francs. And that was the cheapest that we could actually find. So catering is the biggest cost. Venue, we asked the University of Rwanda if they could provide a free venue. And it took a little, discussions with some administrators, but that's possible. I highly recommend trying to get a free venue. If you do not get that, your venue will definitely be highest cost. And the other training that we did in the past, which was similar to BEC, before the BEC came out, we were doing this type of training, and we ended up paying approximately, I would say, $2,000 at a conference room that was like this, but at a hotel. So those are some of the options. Logistics-wise, that's a really, really good question. Other costs that you might want to consider are flying in a master trainer, which we have to do for the Rwanda course. We flew in 2 master trainers just in case one dropped out at the last minute. And according to AFEM, there is some cost associated with that. There should be a stipend. And I think if you guys are doing the course in Africa, you should definitely discuss that maybe with Swati, because in order to have a BEC in Africa, usually you might have to talk to AFEM about that. Other costs? Pens, paper, things like that. The materials, so we had a supply team, and the supply team was able to gather everything they needed and basically tell the rest of the group what we need to be brought. So I think breaking this up into supplies, venue, registering of participants, and certification. Those are like big, large groups that you can break your team into, and basically have meetings like once a month or twice a month towards as you get closer to the course. Is extremely helpful, and that way you're not going to be entirely on your own. So that's super important. Good logistical questions. Yes.
Could you say again, given that this funding TOT is moving where that is now for leadership or?
The fast track, the theory behind it is that it's for the PM specialist, and so this becomes, in lieu of having to take a BEC 5-day course and the TOT, you do the TOT assuming that, all this information is known to you, and then you become a professional trainer without the initial BEC. Does that make sense?
Yes, thank you for saying that.
Yeah, no. It's confusing because literally, like, I found this out like 2 weeks ago. Yeah, any questions? Yeah.
So we are this provisional trainers.
Yes.
Okay. You guys are provisional trainers, that is huge. Yes.
So in order to become master, then you have to not be in a TOT, but also teach the BEC course a couple of times, and then you can be a master trainer.
Correct.
So under your
So to become a registered trainer, you do a TOT, a BEC under a master trainer. You do that twice and become a master trainer. So that's the process of it. But bear with us as it changes daily.
Is there a process for getting into the master trainer?
Yeah, that's me.
Yeah, that's which is so important to know that, because it was, in the beginning, it was kind of hard finding the BECs so that we can all progress in our training. So the contact person is shown on email. Okay.
So, once you're a provisional provider, do you train just the BEC course, or can you also do TOT?
Oh, yeah, you can do TOTs. Yeah. Good question. Yeah, this is, I think, the slide that we get the most questions. So feel free to ask. I had to read this definitely, I would say, 10 times before I really understood. Good. Okay. Oh, that's so favorite part. Okay, so I guess I'll start. So, first of all, using an icebreaker is really important in your local, countries, in your context. It's a great way to, get everybody comfortable with one another. And Travis led the icebreaker in Rwanda. How'd that go, Travis?
Did not go well. Did not go well.
Did not go well at all. Why do you think that is?
I'll talk a little bit about it in our what not to do, which is my lecture, but it's you need to know the culture very well that you're going into. Somebody who's been living in Rwanda for a very long time characterized it as, because I've been in the UC Kenya, and they said Kenyans are Californians, or Rwandans are Japanese. So our icebreaker was to go around asking people to tell things about themselves, and it was like people's faces were like absolutely blank, eyes were super blank, nobody was talking.
So
and it was
quiet.
one of the more painful moments of my presentation life. So,
Because he's such a good teacher, and I don't think we expected that. None of us did. None of us knew really what to do. So how did we break that?
you mercifully ended it.
Mercifully ended it. Yeah, that did not work out really well. So you'll have to give it a shot. If it doesn't work, just move on. And just maybe think of something different to do later. For us, that happened to be the medication jeopardy. And if I would have known that, I probably would have done maybe like a little bit of the jeopardy every single day. That probably would have done really well. But for future context, we'll do that. So we're going to try the icebreaker here. I'll start. My name is Nasreen. I'm the director of the Global Fellowship at Brown. And one one interesting fact about me is that I climbed Kilimanjaro. Well, actually, I should clarify that. I almost made it to the top, and then I got pace and had to be like carried down. So, maybe I'll try again. Or not. I'm gonna start here. Or if you don't want to touch the mic with COVID, just yell. Where? Yes. Name a fun fact.
Fun fact. So I worked for not a fun fact about me. I was homeschooled all through my high school existence. Interesting. I didn't know that about you.
Hey there, I'm Maggie. I'm a resident at University of Washington in Seattle. My fun fact is about 3 weeks ago, I was in Peru with my family, got COVID, got stuck in Peru for an extra week. Had to wait until we recovered to be let back in the US, but now glad to be back.
Were you stuck in your room?
No, we weren't like locked in a room. I think really we sort of, locked ourselves in a room. But yeah, it was not really intense.
Actually, a vacation.
Sure.
Hi, I'm Lee. I'm a resident over at UCF, and fun fact, I used to be an epidemiologist for my school, so this is like super fun experience.
That's very cool.
Hi, I'm Katie. I'm one of the global health and rural health fellows at University of Washington, currently in Cambridge. And I once did a 11-mile swim.
I'm still this. I haven't spent 11 miles, so I was wondering.
Hi, my name is Amelia. I live in Baltimore and work in office. My fun fact is that my mouth is in a piece of video art about women's relationship with food. And I'm putting a truly staggering and disgusting amount of Twinkies in my mouth at one time. I was the representative of an American mouth.
I'm a fellow at Hopkins. Fun fact, I was at the eruption at Mount Kilauea, I think, on the Big Island in Hawaii, so I got to see that last October. No injuries? No.
Hi, I'm Elise Lessick. I'm the Global Health Fellow at Carolina's Medical Center, and my fun fact is I was born in South Africa.
Hi, I'm Tanya, I'm one of the residents over at UT Southwestern in Dallas. My fun fact is my last name in Chinese means bear.
Hi everyone, I'm Mama. I'm one of the incoming fellows at UPenn for Global Health. My fun fact is, and it needs some explanation, so bear with me. It's not my fun fact, I'm actually taking it from my dad. He enjoys like having weird animals around, so there was one time where I came home and he was, and this is a completely true story, had an alligator on his like abdomen, a live one. He just wrapped like the mouth of it, and I came home from like a basketball tournament in middle school, and I came home and he was just hanging out, petting an alligator. So I feel like that's a pretty interesting fact about my dad, which I'm just gonna take. And then he also had a pet Asian, so.
Wow.
Yeah.
That's amazing.
Hi. Bye. I'm Michelle. I'm one of the faculty at Stanford in the global health section. My fun fact is also animal related, but not quite as interesting. I grew up on a farm in the middle of central Illinois, and so I got attacked by a sheep when I was 7. I did not get seriously injured because my dad was there and was able to get the sheep away, but some idiot neighbors decided to train a sheep when it was a baby to headbutt people, and therefore it kept headbutting people as it got bigger. That did not go well.
I didn't know she could be that aggressive.
He wasn't aggressive, he thought he was playing. And so it's just, people are stupid when it comes to animals. Don't train baby animals to do things that's not cute when they're big.
Also, I don't endorse keeping an alligator.
Or that.
Well,
I've always wanted to live on a farm. Allison knows that because we worked together previously. So I'm jealous. I've been in Saddam Hussein's palace in Iran, but I've never sat on his lap. I grew up in a hotel. And so until about the age of 5, I thought if you picked up any phone, you could order chocolate ice cream, which has been a downfall since then.
So hi, my name is Alex. I'm a junior faculty member at Emory in Atlanta, and my fun fact is that I also did a pediatrics fellowship and recently learned that a foreign body presentation in a dog is very similar as it is to a 3-year-old child, when my 90-pound beast swallowed an entire tennis ball.
I'm Joe. I'm at Georgetown right now, finishing residency. I'll be the incoming Global EM Fellow at Yale. And over Thanksgiving, this past Thanksgiving, had a virtual Thanksgiving experience, or a dinner with Rami Malek, who's the best actor from the Bohemian Rhapsody movie and in James Bond. His sister is one of the attendings at our hospital, so we were on shift together and we FaceTimed him and had Thanksgiving. We do have an autographed poster in our ED lounge that he signed to the residents.
I'm Sean Boaglio. I'm the current Global EM Fellow at Vanderbilt, and I can fit 52 grapes in my mouth.
Good morning, everyone. I am Sal. I'm the current Global Health Fellow at Long Island Jewish Medical Center in Queens, and my fun fact is for 10 years I was an international soccer player. For New York.
I'm Tegan. I'm a 4th-year resident in Long Island. I'm going to be joining Johns Hopkins Global EM Fellowship next year, in a couple months. I keep saying next year like it's farther away. My fun fact is that I was a international ski racing professional for 11 years. Also, I am suffering from vertigo today, so if I excuse myself, I'm so sorry.
No worries. Do you two know each other? Want to connect you.
Hey everyone, my name is KJ. I'm one of the residents at UCSF. And going back to the animal fun facts, when I was a kid, I had a pet pig that lived in a box in our house. And they're actually really great animals, like very loving, very smart. Yeah, great pets.
What was the pig's name?
Daisy. It was like black and white pig. We put it with a bottle. It was great.
Hi everyone, I'm Rashmi. I'm a intern at BMC. And my fun fact, I studied abroad in Madrid in college for 6 months.
Hey guys, I'm Chase. I'm a 3rd-year EM resident at LA County. Fun fact is that I didn't meet, but was in the bathroom at the same time as the Honduran president at the time in the airport in Houston.
Wait, did you say anything?
No, I didn't know who he was, and I walked out, and everybody was like, that's the president. And then he flew coach on our flight to Tegucigalpa. Yeah.
Hey everyone, I'm Seema. I'm one of the 3rd-year residents at Hopkins. My fun fact is, when my parents moved here, they wanted me to assimilate into American culture and do sports, and they didn't know what. So I'm really good at synchronized figure skating and horseback riding, but I can't play basketball, soccer, or anything normal.
Hi everybody. My name is Mona Lisa Muchatuta. I am Global Health Faculty at SUNY Downstate Kings County in Brooklyn. My fun fact, I was a power forward basketball player for my national team. I was born in Zimbabwe, so I think pretty cool.
Very cool.
Hi everyone, I'm Ahmad. I'm one of the junior global health faculty with Mona Lisa, also of Kings County, downstate in Brooklyn. I don't know, my fun fact is no one can ever pronounce my name. And to spend every shift like training half the staff about how to say my name. That's all I'm saying.
There you go.
No, it's not a ha, it's a ha. It's not from the mouth. Can you teach them? You can tell.
We'll work on it.
So that's fun, right? I think it's so much fun. We get to know one another. It breaks the ice, hence icebreaker. Also, another thing to remember is have the participants maybe put their names on a piece of paper and fold it and put it on their desk. That tends to be really helpful, just so you can call during a lecture. You can call on somebody and make it interactive. That tends to be really helpful. By the 5th day, you'll probably remember their names. And this took about 15 minutes, 20 minutes. It will probably take a little bit longer, so just remember that as you are setting up your schedule. Cool? All right. We're going to move on to teaching and learning.
Thanks, and one more thing. And I don't know if you mentioned this. I just learned this working in Kenya that definitely we want to spend some time like thanking everybody that made it possible. Like those introductions are so important. You know, in like my style of like just getting things started. You know, I would talk about it, just want to like get, you know, any kind of a lecture going, but you really need to like take this time for introductions. It's super important. And thanking the administration, thanking, you know, everyone that's key, make sure everyone has that time. Sometimes they want to say something too, like the administration maybe just help put it on, because that's their time to shine. So giving them the microphone to really talk about how they brought this into their whatever country, that really goes a long way.
That's such an important point. Like, would you invite, if you can invite the Ministry of Health or the head of the Ministry of Health, we should do for one of our trainings, have them do a little speech in the very
Okay. So now we're going to talk about teaching and learning. I'm Liz DeVos. I'm not used to using a microphone, so if I keep doing one of these, then please raise your hand and tell me to stop doing that. It's very important to SAEM that I disclose to you that I am a site PI for informatics. It has absolutely nothing to do with the WHO BEC course. We won't be talking about it at all today, so you all can get your CME without an issue. So what do you all think? Are teaching and learning the same? I see you shaking your head no. What do you think?
So teaching is getting other people to understand and learn something, or is it individual gaining skill or knowledge?
Absolutely, thank you. So you said exactly what our slides are going to show us. Your job is not only to give the information, but make sure that our learners are processing it and able to share it again in the future. So WHO uses Snoopy, which I think a lot of our trainees in the basic emergency care course, again, may not know. So think about those kinds of things when you make your slides. But in this case, Snoopy learned to whistle, or he was taught to whistle, but he certainly did not learn since Linus didn't make it so that the dog could whistle. When we transition from being a learner to a teacher, it's really important to make sure that everyone that we're teaching in the trainer course understands that it's not our job to prove that we are the smartest person in the room, but it is to break things down into digestible pieces of knowledge that the trainees then can use to put together and teach their students to build upon one another for their future teaching. Tell me some examples of what makes a good teacher.
Someone who doesn't just go through the content, but takes the time for feedback and reflecting on what their students actually interpret it as.
Fantastic. So figuring out if your trainees are actually getting the concepts. What else?
Someone who breaks it down into the context of the learners, so maybe situations relatable to them, their experiences.
I like it. Who else has an idea?
Someone who can make it interesting enough to hold a person's attention in order to teach.
Great, keeping everybody engaged.
Someone who's approachable and makes people feel comfortable asking questions.
For sure. Any other ideas? I think you covered a lot of them. The other thing that we're going to talk about a little bit today is the Constructivist Theory. So when we are teaching, we want to make sure that our trainees are able to put the context that we are learning into a construct that they understand. So it's kind of like putting pieces of a puzzle together. We want to take new information and make sure that our trainees can base their previous experiences and their previous knowledge and put it all together in a way that makes it possible for them to remember. If we give them a context and a framework to put it into, then we can come back to that information over and over again and understand it better. When we think about learning theory, we also need to think about the cognitive load theory. Our brain has a set amount of information that we can think about at one time. And as we build our teaching, we need to keep the amount of information that we're giving out to something that's manageable. There's only so much you can think about at one time, and that's our intrinsic load, right? All the information that we're putting together. And so when we build this, we want to also think about the extraneous load. So intrinsic load is all of the information, all of the context. Your extraneous load is the other pieces that are not important to what you're actually trying to teach. So that might be things that are going on in the room, distractions out in the hallway. It may be that your slide has lots of pictures and animations and other things going on. It may be that there's other distractions. It's too cold, it's too hot, things like that. And then the germane load is what you're really trying to get down to, the context that you're giving, the things that you want your trainees to take away. So when we teach, it's really important that we align these so that our trainees can take away from the course what we think is the most important. So we want to try to minimize the red, those distractions, and increase the amount of blue, which is that available brain power to process the information and take away those new concepts. So again, remember that your intrinsic load is that kind of basic brain power that it takes to understand. So you kind of think about that as like the whole RAM of your computer or things like that. Your extraneous load, all the things that you don't really need running in the background. And then your germane load is what we're actually paying attention to right now. And that's what we need to solidify those new connections and make new memories. We want to minimize that amount of red, control our environment, and that may mean how we set up the room. If we're doing small group discussions, we need to have tables or appropriate places to do a small group activity. And also think about how the information is presented. Are the slides appropriate? Is the language appropriate? Are we using appropriate terminology? All of those kinds of things. So, and if we do that, we can minimize that red, increase the blue, and have a better outcome from our course. So there's 4 key pieces to any teaching session that we're doing. The environment, the set, the dialogue, and closure. The environment we've talked about a little bit. We want to minimize our distractions. The set. This is really like a play. We're starting out with an organized program so that we can prepare our group to learn. So this is going to include who is in the group. Do we have an audience that is appropriate for the information that we're teaching? Or more importantly, have we set objectives and learning goals that are appropriate for the learners in our room? And then our dialogue. That's really the actual material that we're trying to teach. And finally, closure. Anytime that we have a course, we should end with an opportunity to ask questions, a clear summary, and a clear end of the course. If things just kind of taper off and we don't really have final closure, we don't review, then people are not going to take away all of the things that you had planned for that session. And so this is really important for the basic emergency care courses. You're not seeing objectives on every single slide that we're presenting each time someone gets up, but they're in the training handbook, and we have a clear idea of where we're going, a map of what we've set out to teach, and assure that we teach it by the end of the course. So let's talk a little more about the environment. We've all been in the room, typically in a conference like this where it is so cold that nobody can listen to anything that we're talking about, right? So Sharon came prepared today, and she brought a wrap so that she wouldn't be cold in the room. You can think about the lighting. The lighting in here is okay, but sometimes we really are going to have to be prepared to hang sheets in the windows because you can't see the slides or other things set up in your environment. So it's really important to see the place where you're going to be teaching before you start the course and be ready to adapt. Think about the layout. Do we need to have small groups? Do we need to move chairs? Do we need to set up more tables? Things like that. And then our equipment, testing your projectors, anything else that you need ahead of time. When we talk about the set, not only are we talking about who's in the room, but also establishing the credibility of the instructor. So again, we want to think about the credentials, make sure that the course resonates with the people who are in the room, but not set out that we are the end-all, be-all, only person that knows this information, but again, we are in a position to transmit the information. You want to be sure that we set out with clear objectives, introduce the topic, and inspire interest. Make sure people understand why it is important that we're teaching this course. In the case of emergency care, engaging all of our nurses and ancillary personnel, general practitioners who may not even understand why the Ministry of Health sent them to that room, to make sure everybody's on board with what we're doing and what we're going to accomplish during the day, and inspire some interest and motivation. We also want to make sure that we understand what's the baseline knowledge of the people in the room. And that can be difficult if you are coming from outside and you're not familiar with the people that you're training. So what are some ways we might need to gauge that level of knowledge? Sure, the pretest would be really helpful. And so that's one of the reasons that the pretest is done beforehand and not right when people walk in the room, so we can get a little bit of information. What else? Sometimes I just ask people to raise their hands and give me a kind of a general understanding of who's in the room. Michelle, you had another?
When people sign up for the course, figure out what their goal is and why they got sent to the course, like nurse or...
Absolutely. Absolutely. And we typically like to mix the groups of people in the room if they're of varying skill levels. Sometimes in very hierarchical communities that will not work well because there may be societal reasons that some people will not participate in the group or won't speak, and so we may have to rearrange on the fly, but try to have a mix of different levels of experience in the room so everyone can learn from each other if that is appropriate where you're working. And then, as I said, learning objectives, making sure everybody knows what it is we're setting out to accomplish. When we talk about dialogue, it's important for the course to be clear, logical, organized, comprehensive, and engaging and interactive. And when we talk about engaging, we want to think about varying how we do our instruction, move around the room, talk with other people, engage different individuals in the room rather than just standing behind the lectern, carrying on the whole time. And then we want to make sure that we're asking questions. We have an opportunity for closure and feedback. Identify what are the next steps. When people leave this room, they want to know, how am I going to take this back to my community? Whether it's training of the trainers and what do I need to do to be certified to be a trainer, or whether it is the basic emergency care course and we're starting a new emergency center at home. And then finalize with a summary. So some tips for presenting. The BEC wants us to vary the tone of our voice and the level of our voice, right? We don't want to talk like this every time we talk. Emphasize the key points, use hand movements, strategic pauses, make sure you're not doing this and taking your microphone and waving it all around. And slowly move around the room. When you move to different parts of the room, that takes people's eyes off of the one point in the room, helps to keep people's minds from wandering. When you make eye contact, you engage some people again. And again, try not to stand right behind that podium the whole time. How do you handle some difficulties with teaching? Some of the common challenges, and particularly when you're teaching in a trainer-trainer course in a different culture, you might find that people are uncomfortable saying, I don't know. I think many of us in the United States are comfortable with that, but we should all be able to admit that we don't know. Sometimes we can do that without using those words, right? And that may be important to teach our colleagues. So what are some of the things you could do? You could ask the group, right? So ask for a suggestion from folks in the room. You could ask a student who posed a question. That's a great question. I do this on rounds every once in a while. Why don't you look it up and tell us at the end of the shift, right? Or we could have a parking lot. I really like in this type of a setting, having a piece of paper or a whiteboard or a chalkboard where we can put questions that either are not germane to the current discussion, things that might be too advanced for this course, or things that we need to come back and look up. Put them to the side. We will come back to those if we have time. We will look them up and come back to them on the tea break, things like that. That way we can be sure that we get everybody's questions answered, we're engaging everyone, but we are not taking away the limited time that we have during the BEC if it's not germane to the discussion. The most important thing, and as a trainer, it's very important for all of you to be sure that your trainees understand, is that we do not want to make up an answer. We do not want to take the opportunity to inject something into the course that then becomes said as WHO said, the BEC said, AFM said, XYD that is incorrect, and then gets transmitted to hundreds or even thousands, as Shama has said now, of trainees mistakenly. So people are going to take what you say to heart, and it's important that we have accurate information that we're teaching. What if you find some part of the course uses equipment that you don't have? Has anybody in this room been trying to teach in a situation where you didn't have the equipment you needed? What did you do?
Sometimes if it's something that I needed and know a way to make a substitute, I can say, okay, so in our hands-on session, we're going to show how we do this without a picture. Sometimes I'll say something along the lines of, we don't typically have this thing here. What do you guys do in this situation when you don't have this thing? Because it allows me, if there are dangerous practices that are being used in the absence of good practices, at least to say, maybe let's not do those dangerous practices. Let's see what's a safer thing to do instead, even in the absence of our best option.
Fantastic. So that gives us the opportunity to learn what's being done. It's giving everybody in the room the opportunity to share what they do and perhaps have some guidance to some other potential options as well. We can definitely improvise, but I really like understanding from the people in the room what they do already. Everybody likes to talk about themselves and how their life works, and we all like to commiserate when we have a tough day or we don't have what we need, right? So I think all of those are helpful. The other thing is if it is something that is essential that we don't have access to in the area, is that something that this course then can help with advocacy to achieve? And sometimes that's the case. Of course, we need to think about the local context and going through the proper channels, but perhaps that's an opportunity for engagement and advocacy. Supporting participants in mentorship is also very important. We may have people in this course that this is the first time that they're engaged with emergency care at all. And so identifying faculty who can be supportive to those folks is really important. In a 5-day BEC course, it would be helpful many times to have the facilitators assigned to a small group of participants so that they can be the first person that they get to know, they feel comfortable coming during question and answer times or come up during a break or even send an email, and allow opportunities for creating a very supportive environment. Faculty should get to know the participants to the degree that we're able, not try to have, in a 5-day course, all the participants off on their own, and at lunch the facilitators all disappear. I think that's something we have to really be thoughtful about, because it's also very easy for us to say, oh, during the tea break would be a great time for us to regroup and talk about organization. And so being mindful about those things and scheduling times outside of the course will make it easier for the course members to interact with the facilitators. consider, like I said, the faculty mentors for 2 to 5 students. And then be around to answer questions about other things that may not be your topic that you stood up and talked about. If somebody wants to come talk to you about something in the workbook or that they read in the pretest, those kinds of things as well. These are the pioneers of emergency medicine that we are all training. And so we want to make sure that we're supporting them. I think that's why we're all here. So what not to do? Don't skip the basics. I think it's really easy.
So you're supposed to give this lecture, but if
You're up. You are up.
This is amazing. All right.
Awesome.
So I talk with my hands way too much to do a microphone. Can everyone hear me? Awesome. Okay. So this is basically just reiterating a lot of what Liz talked about already. So we'll just go through some of these, and a lot of these are fairly obvious. I think the key overarching idea is that we want to create a really supportive learning environment for folks. We don't want it to be judgmental. We are teaching people with different levels of knowledge and experience in emergency medicine. So we want to make sure that we don't, shoot them down or don't make them feel judged or afraid to offer a wrong answer. We just want to get them involved and get them participating. So the decisions that were made for the DEC were made for a specific reason. One of the big things that I think we all, as we went through this, came up with was just the degree of repetition, which we'll talk about a little bit more. There's a reason for that. There's a reason for why it was structured the way it is. And I'm sure, as the DEC, goes to more countries and we get more people involved with it, there will be modifications made over time. But most, the structure and everything that goes into the DEC was made with a specific reason. The other thing is we don't have a lot of time. Liz was mentioning for some of these more advanced questions, it's very easy for us because we're all love to teach and we're all, in academic camp for a reason. We can go on rabbit trails that will lose us 45 minutes, which is, a whole lecture. So it's really important for us to be mindful of the fact that we have a limited amount of time with our learners and make the most effective use of that we can. And then with this said too, it seems like a lot of this is basic to us, which Liz also pointed out. But for a lot of folks, this might be their first exposure to any idea of emergency care. And you have different levels. You have physicians, you have nurses, you have all kinds of people coming from all different kinds of backgrounds. So it's important that everybody we have a common sort of denominator for everyone. So in terms of adding on other skills, people will ask when you go through the skill stations if they can get more training on other things. I remember one of my group asked me about intubation things, which obviously the DEC is not appropriate, of course, for that. It's something that it's good if you want to talk to them and you want to teach more on break time. You can sort of defer that to there, but it's important that everybody gets that basic foundational level of skills that we go through the course itself. And in terms of the questions about advanced topics, those did a really good job of saying you can either table that, you can say that it's kind of goes beyond the scope of the course, or you can see later. One thing that I do as well is I'll share my email address with people so that if they have questions afterwards, after the course, they're welcome to email me. And I've gotten more questions about emergency medicine and just kind of how they can further their training as well. So that can be a really positive way to build relationships where you're working too. So do not impose your own teaching style and culture if it is not appropriate. So Naz brought up a perfect example of this for my monumental failure on the icebreaker in Rwanda. I did not choose the appropriate icebreaker for that group and that culture, and it was painful. Not only just the awkwardness, but also, everybody got to watch me fail, which is good. That's a good example. Everybody fails, and we can take from it, we can learn from it. Oh, I totally learned from it. Yeah, never again will we do that kind of icebreaker in Rwanda. Only in Kenya.
Jeopardy's the way to go.
Yes, exactly. Jeopardy was smashing success. Know your audience. I know a lot of our Kenyan medical students, well, actually they just graduated, but they said that they were not necessarily used to the teaching style that they were doing. They were used to the more, kind of how it was here back in the day with more pimping, and sort of, oh, you did the wrong answer, and everybody's gonna laugh at you, and it was this more judgmental learning environment. So knowing where they're coming from and what they're used to might help you this just kind of feeds into that. The expectations for what you're going to be as an instructor differ, right? There's some cultures that are more hierarchical, and I am God, you are going to just learn from me and sit at my feet. There's other ones that are more interactive. Just knowing where your audience is coming from is really important. This is just a good travel thing in general. Try to avoid ADMs wherever possible because it might not go over well, or people won't understand. Best case scenario, they don't understand. Worst case scenario, it's offensive. So just kind of watch your ADMs, as well as jokes. And then Liz also mentioned this. We try to mix people as much as possible. It gives people, Rwanda, we had people from different institutions. We had nurses, we had doctors. We tried to get everybody mixed just so they could, learn from each other at different skill levels, as well as interact with people at different institutions. So try to mix them as much as possible. But if you're in a society that is so hierarchical that that's really not going to work very well, then you just kind of roll with it and you put, doctors with doctors, nurses with nurses, or one institution with one institution. This is another important thing. In Kenya, this wasn't much of an issue, but in Rwanda, some of the participants also had varying levels of skill in English. So having people that could do French or Rwanda was super important for keywords. And it's important to know too that you won't always necessarily know right away if people aren't understanding, because sometimes people will just sign it on. And they're like, I checked out like 16 slides ago, and they have no idea what's happening. So it's a really good idea to kind of make it as interactive as possible and to check in with people as you move through. Again, do not skip the repetition. You will literally, like, if you've not gone through the BDC workbook yet, you will be like, for the love of God, like, this is the 8th time we've talked about, like, this subject. Like, surely everyone, has it by now. But, repetition is the mother of all good learning. So really reinforcing that will make it second nature to that as well. So that when they're in an emergency situation, they don't have to think about it quite as much. And again, while these are basic to us, like, what are the ABCs? This is a new concept to a lot of people. In countries where they don't have any requirement to go to an emergency department, they don't have any actual emergency physicians. It's people that are, physicians that are repurposed to work at the ED. A lot of these concepts that are very familiar to us, the Parkland formula, things like that, are completely new to them. So just be very mindful of that. And if you don't know, don't make up, answer to the question Liz mentioned. In Rwanda, we had a situation where they asked about snake bites, and they were like local snakes. And you remember that? We were both like, I genuinely have no idea. Like, I will tell you the wrong thing. But yes. Then our local docs, helped out with that, because I'm like, I couldn't even name a snake that's indigenous to Rwanda. Like, I have no idea. So just know your limitations and know what you don't know about the system that they're working in as well. It's super important. Also, do not underestimate local folks. So the way it's usually structured is your local champions. You'll be doing the BEC, and then at the tail end, you'll be doing your training of trainers. So while you're doing your BEC course, it's helpful to identify folks that seem really engaged, really into it, and want to go that extra mile, to then invite them to do the training of trainers, because the ones that are most passionate and the most excited about it are the ones that are going to carry this forward in their own countries, right? So what we want is for this to be a locally driven initiative, right? Like, we can kind of get the ball rolling with the initial education part, but sorry. You have to use the mic. Okay.
Part of what not to do for the whole.
Yeah, don't speak without a mic. And I can still talk with my hands. This is fine. I just need one over. So it's really important to get those people engaged, because eventually, we want, for example, in Rwanda, once we have a bunch of Rwandan master trainers, we step back, we are not needed anymore, we're contributing to the decolonization of global health, right? So that's the end goal. We can just support as needed, but it's really important for us to identify and to mentor those people who will really be champions, not only for the BEC, but for emergency medicine as it develops kind of across different countries. And also, don't let people sit quietly. This can be challenging, depending on what culture you're kind of coming from. I would say engage them in a culturally appropriate way. I think one of the reasons that the Jeopardy Drug Jeopardy was so successful was they could engage as a group, and it wasn't singling out people as an individual. Right? In Kenya, people didn't care. They're like, yeah, I'll talk about myself all day. But in Rwanda, it's more of a collective, culture. So knowing that and knowing the culture and knowing how to engage people appropriately is going to be more constructive than doing a one-size-fits-all in terms of engagement. What's engaging for us here in the States might be terrifying for someone in a different culture, so just being aware of that. Asking the group to summarize is a great way to do that as well. You can say, okay, this side of the room, can you summarize what we just talked about in this module? And that way it kind of takes off some of that pressure for the individual as well. Passive learners rarely learn, which we know. There's a saying that learning is like a workout, not like a massage. So you have to be actively engaged with the learning in order to actually take it on. Otherwise, you're just letting the words wash over you, and it's probably not accomplishing that much. Anybody have any other thoughts, questions?
Can you talk about the pace of lecturing, like how fast or slow you should
Yeah, that's another excellent. So another one of my failures in Rwanda. I have never been accused of being quiet. I have been accused of speaking quickly. And I had three of you were in the back, like waving your hands and like, slow down, slow down. Definitely be aware of the English level of your audience. A pace that was totally fine in Kenya was way too fast in Rwanda. So just be aware that you should speak more slowly, more clearly. And I was told by a couple of people that actually lived in Rwanda for a while, you almost think it's condescending because you're talking like this. A, B, C is airway, breathing, circulation. You feel like you're being condescending by speaking that slowly, but for people's comprehension, it's not really condescending as much as giving people time to actually process what you're saying. So pacing is super important as well. But yeah, no, that's it. That's a great point. Any questions? Yeah.
Is there a good way to prime yourself about the culture that you're going into before you kind of go there and kind of think about things on the fly?
I think there's a couple of different ways. So you can ask your local partners for sure what's more most culturally appropriate. Like in Kenya, we had 2 Kenyan med students that were phenomenal, and we'll be going back there in August, and they're still phenomenal, and we're going to rely on them, quite a bit. There's also resources that you can use. There's a book called Kiss, Bow, or Shake Hands that goes through different cultural practices in every country and goes through, is this a collective culture? Is it an individualistic culture? Do you need to have time at the beginning to thank everyone? And does everyone need to go around the room and give a little speech? What kind of culture you're working in? So there's books and there's other resources as well. But I would say your local partners are definitely going to be the best resource for that.
How and when do you communicate to people who might be eligible or appropriate for TOT?
So I think we probably midway through you kind of get a sense. Maybe on that Wednesday, if you started on a Monday, maybe by that Wednesday you're getting a sense of who's going to talk up, or who's going to speak up more, who's a little bit more engaged. Very early on, it can be difficult because everybody's just getting to know each other. But I think that halfway point is good too because it gives people a chance to plan. If they need to take an extra day off work or if they need to change their plans for that Saturday TOT. We did Kenya a little bit differently because we just did the BEC last year there and no TOT, but we're going back in August and we'll be doing a TOT for the people who did it last year because they've just finished their intern years and it's become very, very apparent who's really into it and who wants to get more training in it. And that's kind of goes in with identifying your champions as well. So yeah, it's usually clear about midweek, I would say. So yeah, good question.
You can also plan it ahead of time, choosing intentionally the whole cohort to be people who are going to be your friends.
Yes.
That's where if you've had a relationship previously, you've got a set of people who are really interested at the end. Just have them all set up to go to a BBC and TOT.
Yeah, absolutely. And that's what we did with our Kenyan med students as well. We knew that they were going to be phenomenal, that they were really involved. So we all just kind of went through everything together. So, any other questions? Yeah.
Do you address the fact that typically work week is not necessarily
It's been, yeah, that can definitely be a challenge. In Rwanda, it was more of a collaboration with the supervisors at the facilities where they were working at. And they knew, 2 years in advance because of COVID, they had ample time to kind of arrange this. In Kenya, our focus was on people who had just graduated from medical school, but before they started their intern years. So we knew that they weren't going to be working anyway. So if you can catch something like that where people are in that transitional point, that's actually a really good time to do it. And we got feedback from some of our participants during the past year that they used the DEC stuff during their intern year with emergent patients, and that was just a great time for them to do it because they didn't have any of the pressures of school. They didn't have to worry about having to be anywhere else, and they were just able to really embrace that time. Yeah.
So other countries have done differently. So Sudan, because they could get the days off in a row, they did every day March. So it was the 2 or 3 months, but they finished. There's other options. I'm not COVID, I was my own college. There's different options to do that because the problems they run into, usually only emergency specialists in that country and so there's creative ways to do it. And then the WHO Academy we'll talk about later is coming up with an online version. So some basic
Because we did the Kenyan team, like before we actually did the DEC in Kenya, we did like 1 lecture a month with Elisa Janiska for many months. And that's how we kind of did it piecemeal, because that's the only way it works with our schedules. So there's different ways to skin a cat. Like if it looks like it's going to need to be something that's more like an hour, and this will be easier, I think, as local capacity gets built a little bit more as we get more master trainers locally. But yeah, it doesn't have to be. This is just something that's an ideal, but other things can definitely work. That 5 days off, if you can get it off, that's fantastic. If not, that doesn't mean you can't do it.
The biggest thing is that you don't have any information.
Right.
So people like that it's because you'll think that it's, like you guys are saying it's repetitive, but it needs to be repetitive because you'll see with the skills stations and all those things that what you told them.
And the max to a session, right, is 30 participants. So if you have a large group of people you want to train, you want to do it in phases. So in Rwanda, we did the immediate group at Truck Specific Hospital in Rwanda and Kigali, and then because that's their emergency care team, and then we include pre-hospital care providers. The second phase is going to be graduating medical students, and the third phase will be general practitioners in rural regions of Rwanda. So you can lay it out in phases as well. Also want to make a plug for, and since it's being recorded, make a plug for this. This is really important. Decolonizing the course is extremely important and something we should think about because, decolonizing global emergency medicine is like a very hot topic right now, and it's very, very important. So as much as you can have the local providers be the ones that are running the course, that they are leading the meetings. And, to be honest, I've tried that in Rwanda and it worked very well. They definitely need assistance. They might not know how to even run the Zoom or how to keep meeting minutes, and those are all things we can help with. So really kind of letting them lead is super, super important.
Yeah, it's an excellent point because if it's ever going to be successful and sustainable, it's going to have to be something that kind of takes off locally.
And then to add that too, that we have a lot of now regional master trainers, especially in Africa and some places in Asia. So I don't talk about it, but please utilize them. I know all of us want to go. I would love to go, but I have to take a step back. There's regional people that can do this work better and they work the topics better. So please utilize that too.
I think really where we come in is funding aspect, to be honest. I think that's where we're very helpful. So getting grant funding, if you're going to have this be a part of a research project, that does, to be very honest with you guys, takes away a lot, I think, from the BEC. I'm a big proponent of research, but just make sure that it's not, restricted. A lot of things aren't restricted, like we couldn't, everything had to be a specific time. Like the pre-test had to be done beforehand, the post-test had to be done, everything had to be checked off.
We had to check and make sure that each line was actually completed. You know, it's a lot to do with research, and I encourage it, but just don't let it take away from the actual goal of the BEC, which is making sure people are learning. That's all I have for this section.
Any questions?